So what is a pneumothorax? This is when you get air entering your pleural space after disease or injury. So instead of fluid, this time you get air. I want to draw this out really quick. So you have your pleural space, and now I'm going to say, now there's air in here, so this big space. This thing gets stuck to the chest wall, so these are the ribs. These are still stuck, but now you have air compressing. You have air in the pleural space. They're causing positive pressure. Normally this pleural space has a negative pressure, but now you have positive pressure, and you're going to get collapse of this lung. And this is the lung right here. Okay, so that's the problem in pneumothorax. Air entering the pleural space after some disease or injury. As you can see in this picture, they're going to have positive pressure on the lung. You're going to collapse of the lung. Now, if you have a collapse of the lung, what's going to happen? On the affected side, the affected lung only, you're going to get shortness of breath, or you're going to feel shortness of breath in general, but you're going to have pain on that affected side, and you're going to have diminished breath sounds. Because your lung is collapsed, so air is not going to be able to flow very well in this collapsed lung. So on that side, you're going to have diminished breath sounds. You're not going to hear very much of it. It's going to hurt, and you're going to have shortness of breath in general. Now, how can we get air into this pleural space? There's many causes. Okay, we divide the causes into spontaneous, traumatic, and iatrogenic. Spontaneous means it just happens for some reason. Traumatic means there's a traumatic cause, so you got stabbed, you got shot. Or iatrogenic, that means a doctor did it. Okay, so spontaneous we can divide into two: primary spontaneous and secondary spontaneous. So primary spontaneous, I'm gonna do my poor drawing again. So in primary spontaneous, you see it's a rupture of subpleural apical blebs in a slim, tall male smoker. So subpleural apical blebs means you have these air blebs right under the pleura, and if they rupture, these blebs have air in it, and this air is going to go into that pleural space. And I'm going to draw it up bigger for you so you can see. It's going to go into that pleural space, and now you're going to get air. Okay, you're going to get air in between the two. And we usually see basically the slim, tall male smokers, for some reason, they happen to get more of these apical blebs, more likely to rupture. So you see more of these primary spontaneous pneumothorax in a slim, tall male. Okay, so you see a pneumothorax in this type of patient, their answer is that he got it from a rupture of a subpleural apical pleb. Now, next is a secondary spontaneous pneumothorax, and that's the complication of underlying disease. So COPD, so basically these like infection, COPD, cystic fibrosis, causing damage to this pleural, and then if you get enough damage, air can leak through, and that's how you can get secondary spontaneous pneumothorax. Okay. Next is a traumatic cause, so blunt or penetrating. So blunt could be like a car crash. Again, damage to the integrity of this lining of this pleura, and the air leaks through. It can be from this side or from this side. Second, penetrating. That's a bullet. I told you, bullet wound, stabbing from the chest wall, stabs. You lose integrity of this pleura. Air can get in. Okay. Finally, iatrogenic. So you can have mechanical ventilation, or just placing a needle or a catheter that penetrates the pleura, and so now you have a hole where air can get through and then enter the pleura. So all of these can cause a pneumothorax: iatrogenic, traumatic, or spontaneous. Okay. What's going to happen? You get air in the pleura, you get collapse of the lung, and so you're going to have diminished breath sound. You're going to have chest pain. You're going to have shortness of breath. Now let me erase all this. And now I'm going to say, if the air enters the pleura on inspiration but is unable to leave the pleura, you're going to get something called a tension pneumothorax. So any of these causes can cause, any of these, spontaneous, traumatic, iatrogenic, can cause a tension pneumothorax, because it's just, if the air is unable to leave, you get a tension pneumothorax. What's going to happen is air is going to enter, air goes in, can't leave. Next breath, air goes in, gets even bigger. Air goes in, gets even bigger. And now you're going to collapse your lung more and more. Okay? There's going to be more and more pressure in that space because air is going in but it's not leaving. So you get increased pressure, you get even more collapse of the affected lung. And it's going to get to the point where you get collapse of the affected lung, total collapse, and compression of the contralateral lung. And what you're going to see is you also get compression of surrounding structures. So you see this trachea here is very telling. See, we have a pneumothorax on this side, and there's too much pressure here. So you get tracheal deviation And the other thing is, what you see in a pneumothorax is you see absent lung markings. You would normally see these low grayish lung markings on this side on the right, but you see here is very clear and dark. That's because the lung is totally collapsed. The lung is pretty much at this point now, okay? It's collapsed because of all this increased pressure from the tension pneumothorax. The other thing is, I want to emphasize this pressure on the surrounding structures. Other surrounding structures around the lung, we talked about the trachea. What else is around the lung? You have the heart around the lung. You have the superior vena cava, okay? So you can reduce the amount of blood going to and from the heart. You can get hemodynamic instability, so low blood pressure. You can have maybe tachycardia. So this can be pretty severe, okay? That's what I'm trying to get at. This can get pretty severe. So this is a medical emergency, so you need an immediate needle decompression and chest tube placement. So needle decompression, same as always, something gets in between your pleura, you stick a needle in, you remove it. Stick a needle in, you open the needle, air can go, now you have an outlet for this air, because remember we said before there was no way for the air to come out. Now you stuck a needle in, so you made an outlet. And then, that's not going to be good enough. You're going to need to have a freaking a tube in here, tube that's going to go through your chest, get into the pleura of the lung for exit of air, continuous drainage, instead of, you don't want to walk around with a needle in your chest. So you want to first of all, you do the needle, take out the needle, and then you put in a tube to drain out whatever air that's going to keep coming in. So that's it for a pneumothorax. So again, a normal pneumothorax is air enters the pleural space, but it can actually leave. There's all these causes: spontaneous, what do we say? Spontaneous, traumatic, iatrogenic. However, if for some reason this air cannot leave on expiration, then you get a tension pneumothorax. That's a big deal, because you can get collapse of the affected lung, and the other problems, you get compression of contralateral lung, and you get compression of surrounding structures. So again, this lung also got compressed. Okay, so that's it for pneumothorax.